Hello everyone. So today we will be talking about eclampsia, one of the important topic in obstetrics. So the term eclampsia is derived from the Greek word that means like a flashing of lightning, and it may occur quite abruptly without any warning pre-manifestation. So majority over 80% of the cases, the disease is preceded by the feature of severe preeclampsia, and the preeclampsia is known as when the preeclampsia is complicated with generalized tonic-clonic seizure and or coma, then it is known as eclampsia. So definition of eclampsia is the preeclampsia with the seizure or coma, and the pathophysiology is same as preeclampsia, and the eclampsia may occur in patient with preeclampsia, or also in the patient who have the preeclampsia superimposed on essential hypertension. The histological and biochemical changes in the eclampsia is similar that of preeclampsia. The cause of convulsion, there are various different causes of why the seizure happens. The cause of cerebral irritation leading to convulsion is not very clear, but the irritation may be provoked by anoxia. The spasm of cerebral vessel leads to increased cerebral vascular resistance, and that leads to fall in cerebral oxygen consumption, and that leads to anoxia. And the cerebral edema, it may contribute to irritation, and the cerebral dysrhythmia increases following anoxia and edema. Also, the excessive release of excitatory neurotransmitter glutamate is responsible, and loss of cerebral vascular autoregulation with forced dilatation and spasm is also one of the important cause for irritation of cerebral, and these all lead to the seizure. And the onset of fit occur most commonly in the third trimester in more than 50% of the cases, and on rare occasion convulsion may occur in early month as it is in hydathiform mole. In antepartum, the 50% of the fits occur in antepartum period. The fit occur before the onset of labor, and more often the labor starts soon after, and at times it is impossible to differentiate from the interpartum one. And the interpartum one, 30% of the cases, the fits occur for the first time during the labor, and in postpartum case, that is 20%. If fit occurs for the first time in the puerperium, usually within the 48 to 72 hours of the delivery. Fits occurring beyond 48 hours but less than 4 weeks after delivery is accepted as late postpartum period. And the intercurrent, and there is something known as intercurrent or antenatal, when the patient becomes conscious after recovery from convulsion and the pregnancy continues beyond 48 hours, and that is known as intercurrent or antenatal antenatal duration onset of fit. And the clinical feature of the eclampsia, except on the rare occasion, an eclamptic patient always show the manifestation of acute fulminating preeclampsia called as premonitory symptom. The eclamptic convulsion or fit, the fit are epileptiform, and they consist of 4 stages known as premonitory phase, the tonic stage, clonic stage, and stage of coma. In the premonitory stage, the patient become unconscious. There is twitching of the muscle of the face, tongue, and limbs. The eyeball roll are turned into one side, and this lasts for around 30 seconds. In the tonic stage, it is also of 30 seconds, and the whole body goes into tonic spasm. The trunk goes in the opisthotonous position. The limbs are flexed, the hands are clenched, and the respiration ceases. And the respiration ceases. The tongue protrudes between the teeth. Sinuses appear. Eyeballs become very fixed, and it lasts for 30 seconds, like that of premonitory stage. And the clonic stage lasts from 1 to around 4 minutes. All the voluntary muscle undergo alternate contraction and relaxation. The twitching start in the face, then involve one side of the extremities, and ultimately the whole body is involved in the convulsion. The biting of the tongue occurs, and the breathing is very stertorous, and the blood stain through the secretion fill the mouth, and sinuses usually disappear. The stage of coma occurs for a very brief period. After the fit, the patient passes on to the stage of coma. It may last for a few brief period, or in other deep coma persists still till another convulsion. On occasion, the patient may appear to be confused state following the fit and fails to remember the happening. Rarely, the coma occurs without a prior convulsion. And the fits are usually multiple. The fits are usually multiple, recurring at the varying interval. When it is very quick, when it occurs in quick succession, it is called as status eclampticus. And following the convulsion, the temperature usually rises, the pulse rate and the respiratory rate also rises, and also the blood pressure also rises, and urinary output is markedly diminished, and the proteinuria is pronounced, and the blood uric acid is also raised. And the differential diagnosis, the diseases which are associated with convulsion or coma are to be borne in mind while arriving at the diagnosis of eclampsia. The diseases are obviously, one is the epilepsy or the seizure disorder, and next one is hypoglycemia, encephalitis, meningitis, and all these conditions where there will be seizure, like posterior reversible encephalopathy syndrome, the cerebral venous thrombosis, the hypertensive encephalopathy, the cerebral malaria in the tropical areas, intracerebral tumor, and hypoxic ischemic encephalopathy. And the absence of previous history of convulsion with presence of edema, hypertension, proteinuria, along with fits or coma during pregnancy or soon after points to the diagnosis of eclampsia. So absence of previous history of convulsion with presence of edema, hypertension, proteinuria along with fit, and this point out to diagnosis. So there will be various complication of the eclampsia. First one, we have the injury, that there can be tongue bite during the clonic state, and that injuries may be found from beard sore, and the pulmonary complication like pulmonary edema due to leaky blood capillaries. There can be pneumonia due to aspiration or hypostatic or infection. There may be acute respiratory distress syndrome, embolism. There can be hyperpyrexia, and basically the complications are almost present in every system. That is every system, like even the respiratory. This is a cardiac symptom like acute left ventricular failure or cardiomyopathy can be occur, and renal failure, hepatic necrosis in also hepatic necrosis such as the capsular hematoma also can be there, subcapsular hematoma, and the cerebral edema, vasogenic edema, hemorrhage, and neurological deficit can be there. And the diminished vision due to retinal detachment and occipital lobe ischemia can be there. Hematological issues like thrombocytopenia, disseminated intravascular coagulation, and the postpartum shock, sepsis, and psychosis can be there. And these all can even lead to the maternal death also, and the maternal mortality in eclampsia is 2 to 20% in India. And the causes of maternal death is due to cardiac failure, pulmonary edema, aspiration or pneumonia, cerebral hemorrhage, acute renal failure, cardiopulmonary arrest, ARDS, and pulmonary embolism, postpartum shock, and HELLP syndrome. And these all can lead to death. And the maternal complications are higher in antepartum eclampsia. And there can be even a fetal complication, like there can be prematurity, spontaneous or induced, intrauterine asphyxia due to placental insufficiency, due to arising outer infarction, retroplacental hematoma, and the effect of drug that are used in convulsion. Due to all this, there can be fetal complication too. Perinatal mortality is very high with around 10 to 20%. Now we will talk about management of the eclampsia. Firstly, we have to do what are the various preventive measures we have to do. The various, in the majority of cases, eclampsia is preceded by the severe preeclampsia. Thus, the prevention of eclampsia rests on the early detection and effective institutional treatment with the judicious termination of the pregnancy during preeclampsia. However, preeclampsia can also occur bypassing the pre-eclamptic state in 20 to 40% versus, and as such, it is not always a preventable condition, and the eclampsia may present in atypical ways. Hence, it is sometimes difficult to predict. Use of antihypertensive drug, prophylactic and anticonvulsant therapy, and timely delivery are important steps in the prevention. The close monitoring during labor, 24 hours postpartum is also important in prevention of eclampsia. And MACB trial showed the prophylactic use of magnesium sulfate lowers the risk of eclampsia. And next is we have the first aid and treatment outside the hospital. The patient, either at home or in the peripheral health center, should be shifted urgently to the referral care center, and there is no place of continuing the treatment in primary care hospital. The transport of an eclamptic patient in a tertiary care center is very important, and the medical team at the tertiary care hospital should be informed beforehand. And as such, a person patient in neonatal and obstetric intensive care management, and during the transport of the transport, we have to follow various important steps, like all the maternal record and the detailed summary should be sent with patient, and the BP should be stabilized and convulsion should be arrested. The magnesium sulfate 4 gram IV loading dose with 10 gram intramuscular is given, and also the labetalol 20 milligram IV is given to control hypertension, and diuretic is given if there is pulmonary edema. And one medical personnel or trained midwife should be accompany the patient in ambulance equipped in the to prevent injury and to prevent injury, recurrent fit, and to clear air passages. And for we have the general management, the medical and nursing. We have to follow the certain medical management things, like call for extra help, communication, control of seizure by the use of magnesium sulfate, intramuscular or IV regimen, to put patient in left lateral recumbent position, to maintain oral airway, to oxygen inhalation, non-breather mask, 10 liter per minute. The comments: IV line 1 or 2, wide bore cannula, Foley's catheter with urometer, to monitor oxygen saturation, pulse oximeter, SpO2 is if they, and it should be maintained. SpO2 should be maintained more than 95%. To monitor vitals, fetal status, and magnesium toxicity. The control of hypertension should be done. There is the labetalol and hydrolyzin, and the fluid like crystalloid solution or colloid can be given. The suction, oropharyngeal suction should be done. A diuretic like pulmonary edema. Investigation to organize the blood: CBC, AST, ALT, LDH, creatinine, uric acid, urine analysis, and protein. This should be done. Investigation, blood investigation, uric acid, urine analysis should be done. And for obstetric management, the prevent injury, we have to prevent injury in tongue bite or fall, and to prevent we have to prevent the complication, and we have to deliver by 6 to 8 hours after the eclampsia, and the postpartum care should be done. So we have seen the overall outline what we have to do in the management. So talking about general management, we have to do the supportive care to prevent serious maternal injury from fall, prevent aspiration, maintain airway, and ensure oxygenation, as we have all just discussed. And the patient is kept in intensive care facilities with railed coat, and the tongue blade is inserted between teeth. She is kept in left lateral decubitus position to avoid the aspiration. The vomitus and oral secretion are improved by frequent suctioning, and oxygenation is maintained through a face mask. And oxygen should be 8 to 10 liter per minute to prevent respiratory acidosis. And the oxygenation is monitored using a transcutaneous pulse oximeter. The arterial blood gas analysis is needed when the oxygen saturation falls below 92%, and the patient should have a doctor or at least a trained midwife for constant supervision. And detailed history are to be taken from the relatives and relevant to the diagnosis of eclampsia, duration of pregnancy, number of feet, nature of medication administered that is outside. And we have to do the examination once a patient is stabilized. We have to do the thorough but quick general abdominal and vaginal examination are made, and a self-retaining catheter is introduced, and the urine is tested for protein. The continuous drainage facilities, measurement of urinary output, and periodic urine analysis should be done. And the monitoring, we have to the half-hourly pulse, respiratory rate, and blood pressure are recorded. The hourly urinary output is to be noted, and if undelivered, the urine should be palpated at regular interval to detect the progress of the labor, and fetal heart rate is monitored. Immediately after convulsion, the fetal bradycardia is common. Fluid balance, the crystalloid solution like Ringer solution is started as a first choice. The total fluid should not exceed previous 24-hour urinary output plus 1000 ml. Insensible loss through lungs and skin. Normally it should not exceed 2 liter in 24 hours. And for antibiotic, we have to give the ceftriaxone 1 gram IV twice daily is given. And we have to give, finally, we have the specific management, the anticonvulsant regime. The aim is to control the fit and to prevent its recurrence. In areas where eclampsia is frequently encountered, it is obvious that the obstetric care is inadequate. In such circumstances, any complicated regimen is unlikely to give any good result. So, magnesium sulfate is a drug of choice. And how this work is that it acts as membrane stabilizer and neuroprotector. It reduces the motor in-plate sensitivity to acetylcholine. Magnesium also block the neuronal calcium intake influx, and the other mechanism of action are like decrease presynaptic release of neurotransmitter glutamate, receptor blockage for NMDA, N-methyl D-aspartate, and the activation of adenosine axon. And it induces cerebral vasodilatation, dilate uterine arteries, increases production of endothelial prostacyclin, and inhibits the platelet activation. It has no detrimental effect on neonate within the therapeutic level. It has got excellent result with the maternal mortality of 3%. However, it doesn't control hypertension. And there are some regimen for magnesium sulfate for the management of severe preeclampsia and eclampsia. One, we have the intramuscular PRIT-CAR regimen. The loading dose should be the 4 gram, 20% solution, IV over 3 to 5 minutes, followed by 10 gram, that is 50% deep intramuscular injection, that 5 gram in each buttock, and maintenance dose is 5 gram, 50% of the intramuscular 4 hourly in alternate buttock. And we have something like intravenous juice pen or CBI regimen, that is intravenous regimen, loading dose of 4 gram IV, slow infusion over 15 to 12, and all this you can just see it yourself. And after giving magnesium sulfate, there can be magnesium toxicity, the loss of deep tendon reflex, respiratory depression, and altered cardiac conduction and cardiac arrest. These are the toxicity of the magnesium. And how we will detect is that if we suspect the loss of the deep tendon reflex, if there is respiratory rate is decreased respiratory rate less than 16 per minute, and urine output is less than 30 ml per hour, and chest pain, heart block, pulmonary edema, and if oxygen saturation monitoring is less than 95%, then that's how we detect magnesium toxicity. And for magnesium toxicity management, we have to stop magnesium therapy. Estimation of serum magnesium creatinine level is done. The injection of calcium gluconate 10 ml IV is given slowly, 10%. The contraindication of magnesium sulfate therapy is myasthenia gravis, moderate to severe renal failure, cardiac ischemia, heart block, and myocarditis. And we have some other regimen apart from magnesium sulfate, like Lytic cocktail, which contains given by Menon in 1961, which contains chlorpromazine, promethazine, and pethidine. We are using diazepam or phenytoin. Compared with other regimen, magnesium sulfate has a better benefit, like it controls magnesium sulfur control fit effectively without depressing effect on mother or infant, reduce risk of recurrent convulsion, and significantly reduce maternal death rate and reduce perinatal mortality rate. And in spite of anticonvulsant regimen, if the blood pressure still remain more than 160 by 110, the antihypertensive drug should be administered. The first line antihypertensive drug are labetalol and hydralazine. The target level of blood pressure is systolic BP should be 140 to 160 mmHg, and the diastolic BP should be 90 to 100 mmHg, and labetalol 20 mg IV is given. Repeated dose may be needed after interval of 10 minutes. Alternatively, hydralazine 5 or 10 mg IV can also be given. And the presence of pulmonary edema requires diuretic. In such cases, 14-1 furosemide should be administered in doses of 20 to 40 milligram intravenously and to be repeated at intervals. And management during feed, in a pre-monitor stage, the mouth gag is placed, and this mouth gag one thing is somewhat controversial, but we can use Goodell's airway safely, and the other, it should be placed between teeth to prevent tongue bite. And the air passage is to be cleared of the mucus and with the mucus of sucker, and the patient head is to be turned to one side, and the pillow is taken off, and the oxygen is given until sinuses appear. And the status eclampticus, the thiopentin sodium 0.5 gram dissolved in 20 ml of 5% dextrose is given intravenously very slowly. The procedure should be supervised by an expert anesthetist, and if the procedure fails, the use of complete anesthesia, muscle relaxant, and assisted ventilation may be employed. And in unresponsive cases, cesarean section in ideal surrounding may be the life-saving attempt. For prevention and treatment of complication, we can use furosemide if in the case of pulmonary edema, furosemide 40 mg IV followed by 20 gram mannitol IV reduces the pulmonary edema, and it also prevent ARDS. Pulse oximeter is very useful in monitor such patient. Aspiration of the mucus from tracheobronchial tube by suction apparatus is done. And heart failure, the oxygen inhalation parental Lasix and digitalis can be used in the heart failure. And anuria treatment should be done in the line of formulated treatment should be done, and the dopamine infusion is given when the oliguria, when the CBP is above 8 mmHg. Hyperpyrexia, it is difficult to bring down the temperature as it is central in origin. However, the cold sponging and antipyretic can be tried. Critical care monitoring, the patient with multiple organ dysfunction need to be admitted in the critical care unit, and the multidisciplinary approach by obstetrician, obstetric nurse, anesthesiologist, neonatologist, intensive care unit team should be involved, and cardiac, renal or pulmonary complications are managed effectively. Neuroradiologic imaging is strongly advised in the postpartum period or for cases with neurological symptom and focal deficit. And talking about obstetric management, this flowchart shows the obstetric management of preeclampsia. The initial control of seizure, patient is stable, cardiovascular, pulmonary to continue medical management. Obstetric management should be done. The clinical assessment of patient and fetal status. If patient is not in labor, and if it is controlled, then we have to deliver the baby. If the baby is term, then we have to deliver. If it is preterm, we have to give stillbirth and then deliver. If it is dead, baby is dead, and then we have to induction of labor and delivery. In any way, we have to do delivery. And the obstetric indication, where delivery can be either induction, prostaglandin E2 artificial rupture of membrane or oxytocin, or obstetric indication, we have to do cesarean section. And finally, if fetal are controlled, we have to do delivery in any of these cases. And if fetal are not controlled and are not reassuring, the non-assuring, we should again do delivery. If fetal are not controlled and not assuring, then also we have to do delivery by each cesarean section, and we have to do postpartum care after delivery. And in the labor, the majority of the cases, the epidural and labor analgesia. In labor, if the patient is in labor, we have to give ARM or artificial rupture of membrane with or without oxytocin, forceps or ventouse, and we have to deliver. And CS in obstetric if there is obstetric indication, and we have to do intrapartum postpartum care. In the postpartum management, magnesium sulfate is continued for 24 hours after last seizure or delivery, whichever is late. Follow-up, we have to do the follow-up and counseling. Prognosis, patient should be followed up in postnatal clinic by 6 week time. And that was all about management of eclampsia. So that was about eclampsia. Then we'll come up again in next video with some new topic in obstetric and gynecology. Thank you. Till then, keep revising and have a nice day.